Attendees are in listen-only mode.
Hello, welcome to the Open Doors Transition Center presentation on kidney disease. We're lucky to have Laura Bingell, our nurse, doing this presentation for us. Just a couple of housekeeping things first. If you have a question, you can raise your hand on the control bar that should be on your computer, or if you prefer, you can type in a question. If you raise your hand, I'll unmute you and I'll let you know that you've been unmuted so you can ask your question aloud. So without further ado, I'll turn it right over to Laura.
Thank you, Suzanne. Hello, everybody. Happy spring. We'll start with this presentation now, kidney disease. It's a very complex health issue that we frequently see in open doors. The organs of the human body are very interdependent, so when one malfunctions, the others are also affected. And you may have heard the riddle, what came first, the chicken or the egg? With many of the conditions seen with kidney failure, it can be difficult to determine which came first. But just knowing that certain conditions are associated is more important in our arena. So today, along with other associated problems, we'll talk about what the kidneys do, some statistics in the United States, some common causes and symptoms of kidney disease, basic information on current treatments. And I hope that this will assist you in the work that you are all doing in helping people with kidney disease return to independent living. Okay, slide number 1. Our kidneys filter waste and extra water from our blood and eliminate these in the form of urine. They regulate electrolytes in our blood, such as sodium, potassium, phosphorus, and calcium, and they help maintain the correct pH balance of our blood. They also release hormones important for the regulation of blood cell formulation, especially red blood cells, the regulation of blood pressure, and bone strength. And interestingly, it takes less than 1 hour for healthy kidneys to filter all of the blood in the human body. Next slide. This is a cross-section of the human kidney showing in the cutout in the upper left there that each kidney contains units that are called nephrons, and each kidney contains more than 1 million of these tiny filtering units. Each nephron is composed of a glomerulus, which is essentially a wound-up blood vessel that does the actual filtering of the blood, and a renal tubule, which receives the filtered fluid. Some of the substances sent through the tubules are still useful to the body, like some of the sodium, phosphorus, and potassium. When the body is lacking in these, the tubules can direct them back into the blood. But if there's enough or an excess, it passes them into the urine. And this is what happens with the extra vitamins from supplements that are over and beyond what we need that can make our urine so colorful and so expensive. Next slide. Acute renal failure happens suddenly. It's usually related to trauma, and people may or may not fully recover from it. About 25% of people that will suffer from acute renal failure will develop chronic kidney disease within 10 years. And so chronic kidney disease is where the kidneys are not functioning well, and it will progressively worsen over time in many cases. In end-stage renal disease, it is a progression from chronic kidney disease, and it's when the kidneys reach about the functional capacity of somewhere around 10%. In the United States, chronic kidney disease affects about 30 million people. End-stage renal disease, 661,000. There are about 468,000 people on some form of dialysis. And it's the group of people that are over 75 years of age that is the fastest growing group needing dialysis. It's the 9th leading cause of death in the United States at about 47,000 people each year, which is more than breast or prostate cancer. And 193,000 people are living with a functioning transplant, but conversely, 13 people die each day waiting for a transplant. Next slide. Kidney disease is often called a silent disease because the symptoms can be very subtle and can be attributed to other already existing health issues. Most people don't realize that their kidneys are having problems. For these reasons, kidney disease often goes undiagnosed and untreated until symptoms, like what we have on the list on the slide, become advanced and troublesome. And the more advanced the disease, the more pronounced the symptoms become. Certain other diseases put people at higher risk of developing kidney disease. The left-hand side is the chicken versus the egg side. I found some egg-shaped bullets to highlight those. And high blood pressure, for instance, can cause kidney disease by damaging the delicate blood vessels of the kidneys. But kidney disease can also be the cause of high blood pressure. Hepatitis, it's a very complex relationship, but to the nuts and bolts of it, it is thought that the damage to the liver produces protein byproducts that irritate and inflame the kidneys as they filter through. So, but it also can go the other way. Cancer for several reasons. First, the treatment received for it, or in certain cancers, calcium levels or sugar levels are affected and can cause damage to the kidney. But on the other hand, people being treated for end-stage renal disease are found to be at higher risk of developing certain types of cancers. So the heart and kidneys can be viewed as codependent. Each relies very heavily on the other to function properly. When congestive heart failure, or CHF, comes first, it decreases the blood flow available to the kidneys. And when kidney disease comes first, a person will become anemic, which means very poor oxygen carrying ability of the blood. This makes the heart work a lot harder over an extended period of time, creating the conditions that can cause CHF. And then on the right-hand side, inflammatory disease like lupus. I know many times some of you have asked about how lupus is associated with some of the things we talk about. In lupus, it can target the connective tissue of the kidneys, and this is called lupus nephritis. And in fact, it was estimated that 40% of people with lupus will develop some degree of kidney complications. Sickle cell disease, there's abnormally shaped blood cells that damage the blood vessels as they pass through. With HIV and AIDS, 30% of people who are HIV positive do develop some impaired kidney function. Diabetes, 30% of diabetics will develop kidney disease. High blood sugar levels will damage the structures of the kidney. And once damaged, think about how people with diabetes have wounds on their legs and their feet that heal poorly. Well, it's not just their legs and their feet that are affected by the poor healing. And premature birth, people that were born prematurely before 32 weeks of age may have what's called nephrocalcinosis, which means that 1 in 5 have calcium deposits in those small structures of their kidneys, the nephrons. And some people who have this will later develop kidney problems in their adult life. Okay, next slide. Acute kidney failure can be caused by medications, radiology contrast dyes, kidney stones, infections, or other types of trauma, some that are listed on the slide. There is a rise in chronic kidney disease worldwide, and it's thought to be linked to the global epidemic of type 2 diabetes and the overall aging of the populations in developed countries. In diabetes, if blood glucose levels are well controlled, kidney damage can be delayed and minimized. We'd already discussed high blood pressure. One genetic condition I'll highlight is polycystic kidney disease, or PKD, where cysts can slowly replace much of the mass of the kidneys, and this will reduce the kidney function. And this also can lead to kidney failure over time, usually as a person ages as an adult. Okay, next slide. Malnutrition and general deterioration of muscle mass is a big problem with kidney disease. This happens because of not taking in enough nutrients and not being able to fully utilize the nutrients that they do manage to eat, particularly proteins. Sometimes supplementation with a specific type of nutrition or altered avenues of nutrition is needed. Usually by stage 3 of chronic kidney disease, which is roughly around 45% of function, anemia occurs for several reasons. Vitamin deficiencies, dysfunction of a parathyroid glands, inflammation, and shortened red blood cell survival all contribute to the bigger factors of decreased red blood cell production. Also, reduced iron stores for the body to use as building blocks for new red blood cells becomes a problem. And notice the egg-shaped bullets again. Sometimes it's difficult to say which came first. Cholesterol levels, triglycerides are not filtered by the kidneys. Enzymes in the liver primarily do this job, but for reasons that are still unclear, liver enzymes are not as active as the kidneys fail. Almost half of people with chronic kidney disease have high triglyceride levels. This alone may not be enough to significantly increase overall heart disease risk. However, combined with lower HDL and higher LDL levels, the risk is significantly increased. Bone disorders in kidney disease, this is the bottom point there. They're very complicated, and there's no way I could cover that, even if that was the only thing we were focused on. So I'm going to simplify it greatly, which is good because, as I said, it took me a long time to try to get a handle on it. First, calcium and phosphorus are minerals that provide the main strength of the bones. They exist in balance with one another unless something like poorly functioning kidneys disrupt the balance. Second, rising phosphorus levels are almost universally observed, starting with stage 3 of chronic disease, because the kidneys are not effectively filtering out the excess. So all of the available calcium in the blood binds to the phosphorus and then is not available for absorption to strengthen the bones. And the body is forced to find calcium to keep binding with this excess phosphorus. Our parathyroid glands, very small glands found near the thyroid, will try to collect the phosphorus in balance. Working ideally, if the level of calcium in the blood falls, the parathyroid glands produce more hormone, which will pull some calcium from the bones into the blood. If this is happening too often, the bones are depleted of their calcium. So remember, too, that the kidney is important in utilizing vitamin D, which is key in calcium absorption to strengthen bones. So the bones are unable to replace lost stores with new calcium. If this happens and the blood levels of calcium are remaining high, this is what becomes a dynamic bone disease. Eventually, the parathyroid glands may kick into overdrive and cause persistently high calcium levels, and this sometimes requires surgery to correct that problem by removing those glands. So taking all of these factors into consideration, controlling phosphorus and calcium is a balancing act with kidney disease. The treatments used to control these and the associated bone disease can eventually contribute to increased cardiovascular risk, even affecting the vessels of the heart itself. 70% of people with chronic kidney disease over 65 years old have cardiovascular disease, whereas only 35% of people that same age without kidney disease do. So much of the medical community consider people with chronic kidney disease to be at equal risk of future cardiovascular event as those who have already had a heart attack. Okay, next slide. This slide shows the impact that the kidneys and heart can have on one another, leading to the disorders we discussed. Starting at the top, the kidneys failing to function cause anemia by not promoting red blood cell formation and not filtering waste correctly, promoting cardiovascular disease. This forces the heart to work harder, pumping harder and faster to get oxygen and nutrients to the whole body. It needs to pump more volume to get the same effect, so it gets tired and weak. The body, including the kidneys, do not get the oxygen and nutrients they need, and so continues the cycle. Heart-associated conditions are the most common cause of death for individuals with kidney disease, at about 50%. Other cardiac complications are closely associated with the development of left ventricular hypertrophy, pictured in the lower left-hand corner there, which is a weakening and enlargement of the powerhouse of the heart, so it pumps even less effectively. About 75% of people who reach end-stage renal disease already have some left ventricular hypertrophy. For these, this translates to a 30% lower 5-year survival rate. Good medical management of anemia and blood pressure early, keeping all the dominoes in the upright position, can reduce the risk of developing LVH. Next slide. About 50% of those with kidney disease have high blood pressure, so it is a red flag for doctors. By the time people are in renal failure, this increases to 90% will have high blood pressure. The goal of 130/80 may be even lower for some individuals based on the overall picture. Different tests may be used to identify changes in the urine and blood for initial diagnosis. These may be one-time random samples with mathematical calculations used to determine 24-hour values, or the doctor may specify 24-hour tests if there are too many unknown variables. This is true of the glomerular filtration rate and eGFR, which the E stands for estimated glomerular filtration rate. It is a measurement of the amount of blood that is filtered by the glomeruli each minute. It is the standard measurement of kidney function. And some of these other tests, BUN is blood urea nitrogen, which is a level of waste product in the blood. Creatinine is another waste product, which is a byproduct of normal muscle functioning. Measuring creatinine clearance means measuring the level of it both in a sample of blood and a sample of urine from a 24-hour collection. And from these results is calculated the amount of creatinine that has been cleared from the blood and passed into the urine. Other chemistries would cover calcium and phosphorus, as we've already talked about, and a complete blood count would indicate if anemia is already present and can indicate if an infection is involved. And then additional testing, basically to see how other things are impacting the kidneys, such as diabetes. Okay, next slide. This is the staging system introduced in 2002 by the National Kidney Foundation based on the eGFR. 3 plastic medicine cups, the kind used in hospitals or that come with over-the-counter cold medicines, would represent about 30 mils apiece. So 3 of them would be the 90 milliliters. This will give you a visual amount of what we're looking for in an average sized individual per minute. And this is why it's called estimated. I have added in approximate percentages to give you a better idea of the functional efficiencies of the kidneys at each stage, but percentages won't routinely be used like this in medical documents that you would see. So in stage 1, the kidneys are functioning normally, but other findings will have indicated that there is some kidney disease present. In the next stages, you see the progressive worsening of kidney function. And for a diagnosis of chronic kidney disease, the decreased filtration rate must persist for more than 3 months. Many people can live out their lives with chronic kidney disease and can manage this on medications and with dietary changes. In fact, half of the people who reach stage 3 won't progress. The other half will progress to 4 and 5 stages within 10 years. But, you know, so is this a glass half full or half empty? So half won't. I'm going to go with the positive. Next slide. Dietary management is an important early intervention. There is no one renal diet. Each person needs personalized instruction from their doctor, and most will and should consult a registered dietitian. Controlled eating for kidney disease works in this manner. Removing the byproducts of protein metabolism is hard on the kidneys. Limiting protein intake decreases this workload. This, however, is a balancing act in maintaining good nutrition. During chronic kidney disease, how much to reduce is dependent on which stage of kidney disease is present. Many doctors will make early referrals for diet and nutrition, and I think this is an excellent practice. Sodium, too much, can promote fluid retention and increase blood pressure. The average American eats way over the recommended 2,300 milligrams a day, closer to 3,400 milligrams. So for people with hypertension or chronic kidney disease, less than 1,500 milligrams of sodium is the goal. Salt substitutes should be avoided since these are usually only potassium, which also must be limited in kidney disease. And phosphorus, which is found in meat, dairy, and soft drinks and cola drinks. Too much of these can damage the bones. This is also very personalized depending on the stage of disease a person is in and their current blood levels. So very early increased fluid intake may be recommended, but if fluid intake is not carefully managed, it can increase blood pressure and can overload the heart. So this is individualized and will change over time. Any new medications or supplements must be cleared with the doctor. Doctors who are not the kidney doctor or nephrologist may even need to be reminded of an individual's kidney disease when they are prescribing new medications. It is never a bad thing for a primary doctor to say, let me check this out with the nephrologist. Next slide. The National Kidney Foundation has established guidelines for doctors to prescribe the appropriate medications for people with kidney disease and its associated conditions. It is generally expected that a regimen of multiple medications will be needed and will change with the individual's condition. For high blood pressure, ACE inhibitors, which are angiotensin-converting enzyme inhibitors, these are medicines typically ending with pril, if you've seen them, like captopril, lisinopril, monopril. Basically, they relax and dilate blood vessels and reduce internal pressure. If cholesterol is high, a doctor may recommend treating this to reduce likelihood of heart disease, and coenzyme Q10 might be supplemented if a statin is used, since statin drugs can deplete this enzyme, which might worsen fatigue. Angiotensin blockers may also be used for blood pressure with a slightly different approach from the ACE inhibitors. Diuretics are used to manage fluid levels, and there are several classes used. This is individualized, taking into consideration the overall picture. Some common ones are HCTZ, Lasix, Bumex. When the kidneys stop converting vitamin D to its active form, when down to about 40% of normal function, the doctor should evaluate them for the need to replace vitamin D. Most people past stage 3, as we already mentioned, will have anemia, and with this, many also have reduced iron stores. So treatment with an erythropoietin stimulating agent, or the acronym is ESA, will improve hemoglobin levels, and this is often paired with iron supplements. So remember the attraction between calcium and phosphorus. So too much phosphorus in the blood will deplete the calcium. Phosphate binders are a group of medicines that are calcium-based. Some are only antacids like Oscal and Tums, but there's also some prescriptions. And they can bind extra phosphate from food when they're taken with meals that will send the phosphorus for elimination to prevent it from taking all the calcium. So it has to be used in combination with a well-controlled diet. Next slide. Because so many people are exploring complementary and alternative medicines, integrative healthcare has really brought, let me rephrase that. Integrative medicine is becoming more commonplace. So to help inform citizens, in 1992, the National Center for Complementary and Alternative Medicines was established at the National Institute of Health, and I provided the website for you there. A very nice website, and it covers topics like herbs, acupuncture, massage, and how specific alternative complementary treatments can be applied with a specific health condition in mind. So you could spend a whole day kind of researching that, and it will take you to current studies as well. People with kidney disease need to be really cautious with these things by remembering that anything that they take into their bodies may be processed out of their bodies through the kidneys. For this reason, most doctors will advise against Chinese herbs. Something even as common as parsley can be damaging to someone with kidney disease. And this is another reason why they should really be involved with a dietitian. And the reason for this is that parsley is high in potassium, it's high in phosphorus, and it promotes water retention by holding on to sodium. So for some people, it could really be a problem. Complementary therapies that help reduce anxiety and blood pressure may be very useful, but open communication with medical providers is always essential. The doctor might prescribe specific vitamins because dialysis can remove them with the filtering of the blood, like certain B vitamins, but megadosing on vitamins should be avoided. Sometimes when people feel they're getting colds, they'll megadose on vitamin C, but the vitamin C for someone with kidney disease should be limited to what's in their prescribed multivitamin, and this is because it is filtered through the kidneys, and if not filtered out effectively, vitamin C can turn to crystals that will deposit in the bone and soft tissue and can cause kidney stones. But if not kidney stones, at least they're painful. And then fat-soluble vitamins can rise to toxic levels quickly with renal disease. So here's my plug for pharmacists. They're a very good resource if an individual has one they trust and sticks with that one. Open communication is good. Inform your pharmacist of all your medicines, including any over-the-counter and any supplements. They can help with prescribed medications, and they also have resources to help with herbs and other supplements and can help check for safety in any interactions. Next slide. For many people with kidney disease, poor nutrition may be the indicator that dialysis or transplant is needed. This usually becomes necessary when 90% of kidney function has been lost. Dialysis can replace about 20% of the function of the kidneys. Transplant, about 50%. Remember that people often don't know that they have kidney disease until it's quite advanced because a lot of function must be lost before it becomes evident. So these percentages offer a lot when we look at them in terms of how a person feels and functions. A nephrologist will prescribe what dialysis is needed by keeping close tabs on an individual's overall health and lab results. And I have representation of what those prescriptions might look like there. Lab work, primarily the BUN, results before and after dialysis are important to establish what is called dialysis adequacy. So, diet often becomes trickier during end-stage disease. What is recommended is very dependent on the type and frequency of dialysis, also on other coexisting conditions like heart disease and diabetes. People may need more protein when they're getting dialysis than they did during chronic disease, but the type of protein is important. For instance, nuts are high in protein, but they're also very high in phosphorus, so it may not be the best choice for someone who needs to limit their phosphorus. Peritoneal dialysis usually permits a person to be a little less strict with what they eat, since it is a more continual process. The individual instills dialysate fluid into their abdominal cavity, or peritoneum, that's where the name comes from, by means of an indwelling catheter. It remains there for a period of time doing its work using the natural membranes of the body as the filter before it's drained and replaced with new fluid to do it all over again. So they can eat a little less strictly. People on dialysis will have a clinic team coordinating their treatment, whether they're getting their treatment in a clinic or at home. This includes the nephrologist, dialysis nurse, technicians, medical social worker, and a registered dietitian. Individuals are encouraged to participate in their own planning meetings as part of the team. In transplant, in 2015, 100,000 Americans were waiting for a transplant, and of these, 16,000 did receive transplant. And in their lifetime, some people suffering from kidney disease will require more than one transplant. After a transplant, as long as the kidney is functioning well, a heart-healthy diet like what we should all be eating is likely what will be recommended. Next slide. Here is what a home setup may look like. On the right-hand side, nocturnal hemodialysis and the machine there required. And on the left-hand side, manual peritoneal dialysis. I couldn't find any photos on this one, just this. And I thought, well, I think I might like a little more comfortable chair. But in reality, the exchange of the fluid usually takes less than an hour. So it really, that might be the way he likes to do it.
Laura, do people usually do dialysis at home or in a clinic?
It can be done either way, and we will talk a little bit more about that in my recommendations for the people we're serving. But the majority of people do clinic. It was somewhere around like 90% utilize clinics and 10% do home.
Okay.
This diagram represents a general hemodialysis setup, and the grayed area represents the dialysis machine. Depending upon the machine, if a person wants to explore home options, supplies would be needed, which would include filters, solution, disinfectant, syringes, needles, medicines, blood tubes, water test kits, water treatment tanks. Some machines require electrical and plumbing modifications in the area where the dialysis will be done, and also a backup plan for emergencies like power outages. A generator can be used, or a more elaborate setup with a power inverter is cheaper but a little harder to set up. At a minimum, the power company should have this individual on the list for people who are prioritized for power restoration. So home treatments do take thought and preparation. Any MFP participants and their families who are considering home dialysis should be made aware of these things. Clinics are required by law to have documented emergency plans for power outages and disaster. These plans assist their clients to have emergency kits that would include medical documents and alternate clinic locations. People that have end-stage renal disease simply cannot just skip a treatment. So this may present some challenges for the transition specialists when you're planning their move or their discharge from nursing facilities. It's probably best to plan for days that they're not scheduled for dialysis if they can be avoided. Next slide. This is a general comparison of the different types of dialysis that are available. And you can see some of them in the where are home and some are clinic. It's my feeling that a clinic setting is better for most of the people we're working with. This is people who would likely benefit from close monitoring by medical personnel, who would have difficulty setting up their own equipment or keeping to a schedule without the resources readily available at a clinic. And once they're at a clinic, many of the healthcare tasks they need to be done can be done while they are there. Home dialysis, on the other hand, can be ideal for someone who can maintain very good technique and wants more control to work around a busy home or work schedule, or for someone who wants to travel. In clinic, overnight or nocturnal typically will only be available in metropolitan areas. I checked with some clinics that serve rural areas, and they will support home nocturnal dialysis by training an individual and their care partner to do this with on-call coverage for off-hour issues, but issues that can't be managed by the individual and their care partner and the on-call service may need to use emergency services on some occasions. There is in some centers what is called in-center self-care, which I found very interesting. An individual is given training and encouraged to do as much as is possible for themselves with the clinic staff available for support. And that intrigued me. Dialysis can't replace all of lost kidney function, but people who do dialysis more frequently and for longer periods of time usually report feeling better. Remember that our healthy kidneys filter our blood numerous times every day, so more frequent and longer times is closer to the ideal. People who opt for daily home hemodialysis or peritoneal dialysis, since it is continuous in nature, are typically able to be less strict with their diets and what they drink, but these types do require a lot of personal commitment and knowledge and self-care. Okay.
So, Laura, can I just ask, so you're talking about needles versus non-needles.
Yes.
Do people with dialysis sometimes have ports that are already established? for the dialysis?
Yes, yep. And that actually is the very next slide.
Oh, sorry.
That's okay. Your train of thought is going just where I was expecting people would go.
All right. Because I was just
So
thinking if you don't actually have to inject yourself, if it's just a port, it seems easier than having to inject yourself with a needle.
Yeah. So I'll just go through this. This is what is preferred, is arteriovenous fistula, and I have them in order of preference, that or a bridge graft. So good medical planning will encourage having an access placed before it is actually needed during the later stages of chronic disease. The arteriovenous fistula is surgically created by connecting an artery and a vein together, and it's usually done in the lower part of the non-dominant arm. It will require 1 to 3 months to mature before it can be used for dialysis. For someone who doesn't have a lot of good veins left because of maybe frail health, synthetic material can be used to form what's called a bridge graft. It can be ready a little bit sooner, but it also needs to be replaced, whereas the arteriovenous doesn't need to be replaced very often because it has the ability to heal itself, whereas a synthetic material does not. So during hemodialysis, 2 needles are put into the access, one to remove and filter the blood and one to return clean blood to the body. When these types of accesses are used in the arm, a person should avoid carrying heavy items across them, not wear any clothing that might compress, not allow blood pressure or blood draws to be taken from that arm. Wearing a medical alert bracelet on that arm is a very good idea in case EMS are called and they want to put a blood pressure cuff on the person right away. That's the first thing they're going to notice, and that'll help protect that. In some cases, people can have a central line. However, those are usually reserved for only acute needs. Say, for instance, you have a person newly with acute renal failure and they need it temporarily. They can put in a central line or a port, as you mentioned, Suzanne. But typically for ports too, these are very large bore needles that they use, and the infusiport type thing that they use for chemotherapy wouldn't work well with this large of a needle. It would perforate and make too large of a hole. So that's why those under the skin ports don't work well for this. Plus they need to go in and out, not just in. So with the peritoneal, it's the catheter that goes into the abdomen, and that's why there's no needles there. The catheter remains in the abdomen with a occlusive dressing over it. Did that answer your question?
Yes, it did. Thank you.
Okay. All right, so the next slide. Home hemodialysis requires a care partner, someone who will train with the person for 3 to 6 weeks, make the time commitment, set up equipment, perform safety tests, insert needles into the access device, keep records, maintain a sanitary environment, order supplies, and troubleshoot any problems. This truly is a partner, and they must be as motivated and committed as the individual getting the dialysis. They usually have to make adjustments to their own routines and schedules to accommodate this new dialysis schedule. A care partner should be calm, patient, and able to respond well in a crisis. People with severe phobias to needles or blood may not be the best choice. Being comfortable around medical equipment and procedures to start is helpful, but many people with an initial fear can overcome these with motivation and a good training program. Next slide. An MFP participant with a functioning transplant will require much less planning from you than someone who is on dialysis. Their most important medical consideration is, will they be able to take their medications on their own, or will they need help? Anti-rejection medications are necessary for the lifetime of a transplant, so it is vitally important that they're taking exactly as they are prescribed. If these medicines are stopped, rejection is likely to occur, and the kidney transplant is likely to fail. So rejection is an expected side effect of transplantation, with about 30% of people who receive a kidney transplant experiencing some degree of rejection. But most of these rejections occurring within 6 months after transplant can be managed if they are identified and treated immediately. So the next consideration would be, do they and their caregiver know what signs and symptoms to call the doctor about immediately? And those I've listed at the bottom point there of fever, pain, unexpected sudden weight gain, fatigue, nausea, vomiting, or changes in urine output. These should be immediately called to the kidney doctor. Living donor kidney transplants are the best option for many if they are available. When you look at these statistics, the surgery can be planned first off, which leads to better outcomes. So there's lower risks of complications, lower risk of rejection since all the testing has been done beforehand, better early function of the transplanted kidney, and no need to be on a waiting list. So it does have slightly better outcomes, but when you look at the difference, it's really only a 3% difference with a deceased donor 3 years out. So the survival rates of the transplant and the recipient are both very good in either scenario. So now we talk a little about payment. When Medicare was first established, end-stage renal disease was not covered for treatments because it was considered a fatal disease. As dialysis became more available, end-stage renal disease came to be viewed as a chronic condition. But lack of insurance coverage became a barrier to receiving the very expensive treatment. This led to the passage of the Medicare ESRD program in 1972. The original intent of the program was to steer more people toward home self-dialysis. So home treatments had a shorter waiting period for this program to start, and still do. Coverage can start with day one of treatment and even be backdated as long as training for self-care starts before 4 months. The in-center self-care training that we mentioned in a previous slide can also qualify for earlier Medicare coverage under this idea, as long as the training is done in a CMS certified center. I read in one MLTC handbook that they do not cover chronic renal dialysis, so people do need to apply for this program when they're on MLTCs. In most cases, I believe. As I said, I only read one book, but I'm thinking they're probably all doing the same thing. A local clinic that I called and spoke with someone there informed me that on day one of treatment, they initiate the process of helping people sign up for this program. And then they notify the local Department of Social Services to help start the application process as well. And in the end, about 90% of people do get some help through this program.
Laura, we have a question. Do you know what the requirements are to get on the kidney transplant list?
Oh. I'm looking through my pile because I was afraid somebody was going to ask that and I wouldn't remember.
Well, we can get to that later if you want.
Well, I can tell you what website to go to look for that if you want it. It's unos.org, and it is the National Regulatory Commission for Transplant.
I think it is a good question because it's probably a balance between, are you healthy enough to survive the transplant surgery, but are you sick enough to be at the top of the list to receive one, right? Would you think that's probably what they look at? They want the greatest chance of the kidney being successful, right?
They do, yes. You have to be able to pass surgical clearance, for one thing. So when you think about a lot of the things that we have going on with people with kidney disease, such as diabetes, left ventricular hypertrophy, congestive heart failure, some of these things would disqualify them from being on the list because they're not good surgical candidates. They, like you said, Suzanne, they probably got a pretty low percentage rate of actually surviving just the surgery, let alone the threat of rejection.
And since we're taking a lull here, with the Medicare covering the end-stage renal disease, isn't end-stage renal also one of those immediate qualifiers for SSD? Am I
In most circumstances, yes. Yep.
So that normally when you apply for Social Security, there's a fairly lengthy review process, blah blah blah. But if you have certain conditions, it's an automatic. You're going to be approved, and if memory serves, end-stage renal was one of those.
Right, and for this reason, that fact that they have this program because they determined that people did not have coverage to get the treatment otherwise.
Right.
Mm-hmm. So, but there's some interesting things that go along with that as well, that are being argued at the moment by advocates for people with renal disease as well, that the program will only cover transplant anti-rejection medications at this point for 3 years. So, I mean, some of these things are still being argued to improve the program because, you know, the transplant, we're certainly hoping will last longer than 3 years. And we know that they need to be on these medications for the lifetime of the transplant. So it's not like they're going to be able to stop it. They have to cover it somehow.
Right, exactly.
Mm-hmm. Okay. All right, can we go to the next slide? Okay, the role of rehab therapies. Rehabilitation strategies help in any chronic condition, and we have always touched on these in any of the different conditions we've spoken about. For people with kidney disease, and especially people on dialysis, they will have a considerably lower exercise tolerance and probably more muscle wasting than a healthy person. So the rehab regimen really does need to focus on minimizing disability and promoting independence while considering age, functional limitations, and other existing conditions. I like the definition that the World Health Organization gave rehab: the use of all means aimed at reducing the impact of disabling and handicapping conditions and at enabling people with disabilities to achieve optimal social integration. So I thought that was well stated. So when assistive devices are anticipated, using them early is a good strategy, and this is where an occupational therapist can come in. And using them early is to gain competency and comfort with them before they become absolutely essential. And for some people, this is hard to convince them to start using a cane before they feel they need it, or whatever assistive device it is. But I can't tell you how many people I've seen using canes, using them incorrectly, and then wondering why they end up with a back injury. So I'm a proponent for using things, learning how to use them early. Okay, next slide. For most people with end-stage renal disease, there's a neuropathic component to their pain. First, because many are diabetic, but also because of the buildup of toxins in the blood from the failure of the kidneys to filter it. This can cause it. It's called uremic nephropathy. And the World Health Organization recommends an analgesic ladder, which I have represented on the right-hand side, to control pain and avoid high opioid doses. And the concern with opioids is that they may worsen or complicate symptoms already prevalent in dialysis patients, such as cognitive impairment, sleepiness, nausea, vomiting, loss of appetite, and itching, and may further damage the kidneys in high doses. They may be used, just not first. Some antidepressants and anticonvulsants are showing promise in helping to treat neuropathic pain, and always keeping in mind that adding a bowel regimen and other supportive medications is also helpful to minimize pain. This condition, DRA, dialysis-related amyloidosis, can happen in people who have been on dialysis for more than 5 years, and it's typically people that are over 60 years old. It can happen with either hemodialysis or peritoneal. It develops because a specific protein is not filtered out effectively by the current filters we have, and they clump and deposit in bones, joints, and tendons, causing pain, stiffness, and fluid buildup. And it can actually lead to ligament injuries or tendon injuries, often associated with like a carpal tunnel syndrome. So sometimes occupational therapy needs to come in and form splints. Sometimes surgery is needed to treat the manifestations of it, and then sometimes anti-inflammatory medicines. But successful kidney transplant will stop it from progressing. And more is better with dialysis. More frequent, more lengthy, filters out more. There is research being done on improving filtering. One filter was approved in 2015 for treatment of those who already have DRA, and it's only approved under a special clause of humanitarian use, meaning that it can be used to prevent suffering for people who already have it, but it's not approved to use basically for everybody as a prevention. And how long that will take, I have no idea. Okay, palliative care. Many people have a poor understanding of palliative care, thinking that it's terminal care or giving up on life. Truly, it's not as much about dying as it is about living the days that we have left in a manner that best suits us. So it's an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness, to prevent suffering, to correct problems, whether they're physical, psychosocial, or spiritual. So the need for advanced directives in early stages of kidney disease really needs to be emphasized. As studies have shown, approximately 70% of dialysis patients have either moderate or severe cognitive impairment on formal testing. For people who,
again?
well, I said approximate, but what I have listed is actually 73.
Wow.
73 on formal testing, 73%. So before a person gets to end-stage renal disease, they really need to be thinking about their advanced directives. Social workers and clinics can be helpful, but doctors' offices should be offering assistance at every visit. And all of us at every one of our visits should actually be asked about it if our doctor doesn't already have it on file, if we have an advanced directive. And each one of us should. I can't emphasize this enough. So who would you want speaking for you if you became unable to speak for yourself? Does this person really know what your wishes are, and can they be relied upon to represent and uphold these in a crisis? And this discussion has to take place before a crisis occurs. So people who have the right to make these decisions also have the responsibility to make these decisions, and we need to make them when we have all our cognitive wits about us, if at all possible. So in New York State, the acceptable forms are the healthcare proxy and the MOLST form. If you haven't seen a MOLST form, it's the medical orders for life-sustaining treatment. And these are signed usually in the doctor's office after the doctor has had a discussion with an individual with a serious medical circumstance. So they go over, what would you want done if? What would you want done in these circumstances? How much would you want done? So a living will can be helpful, but it's not legally binding by itself in New York State. So, and if an individual does not want to be resuscitated, a proxy form will not stop emergency responders from performing CPR. And approved in-home DNR or MOLST form indicating DNR are the legal forms. But most EMS providers will actually look for a DNR alert bracelet. So when an individual decides to discontinue treatment, since we're talking about DNR now, a hospice referral should be made. Many palliative care teams are also the providers of hospice in the community, and this does make the transition a bit easier. Next slide. The reality is that there is no cure for end-stage renal disease today. Each treatment, whether it's a type of dialysis or a transplant, has its own set of rules that becomes a chronic condition that will progress. If someone is experiencing hopelessness because of the new realization that their kidneys have failed, sometimes a trial run period of dialysis can help them adjust. But for others, choosing hospice means that the person has decided to discontinue active treatment after a period of time, sometimes many years. Hospice services, or even during palliative care, counseling can be provided for individuals and their families to help them come to good decisions. So once the decision is made to discontinue dialysis, death will follow anywhere from 1 day to a few weeks. And this is primarily how hospice services and funding are geared, that dialysis, a treatment, will stop, but there are some exceptions. The quote that I have listed here is from an interview on the Renal Support Network of Celeste Castillo-Lee from December 15th, 2016. And she clearly shared her journey and the conditions that led her to choose hospice services at the time that she did. And I've included a link in the resources page for any who are interested in hearing the interview, and I encourage you to. She was quite a remarkable woman. She was continuing dialysis at the time of the interview while on hospice services for palliative purposes. It made her feel better, with the understanding that she could discontinue it when she felt it was time. This both helped her maintain the best quality that she could and her ability to exercise some control over her own care. So these things can sometimes be successfully argued. Okay, and often with hospice care, pain is often better managed. There does not seem to be as much hesitance on the part of doctors to prescribe pain medication when they know somebody is on hospice. Okay, next slide. Caring for your body is your job. So here's my prevention page. It's a recurring theme in managing chronic illness, especially with renal disease. Many of the people that had been interviewed that I had listened to as I was preparing for this stress that they did much better when they looked at it like, this is my job to take care of myself. This is the only body I have. It's my job to take care of it well. And this attitude really can be applied before chronic health problems occur and hopefully be used as a prevention. So I would like to encourage everyone to know what your blood pressure is, know your cholesterol level, practice healthful eating, reduce salt intake, be physically active, weight management, stop smoking, take medicines as recommended, even over-the-counter ones. And if you're a diabetic, keep your blood sugar well controlled. As we age, it becomes even more and more important to have an established relationship with a primary care physician to help us sort through issues that come up and identify problems early. And don't neglect mental and emotional health. So by keeping a positive attitude, even in the face of some chronic health problems, this has also come up in every webinar, that all the individuals with the best outcomes have shared this advice in common to keep positive attitude. Notice that the happy egg is the one on top. Next slide. Research that is being done, as we mentioned, improving filtering. There's always research in genetics, biomarkers, identifying people that are at higher risk for kidney disease to ramp up screening, so screening for early identification, how it progresses, how to slow progression, prevention of cardiovascular disease with improving transplant outcomes. And there is actually some research being done on developing an artificial kidney. It's an artificial implantable device that they're calling biohybrid, the size of a soda can. And the University of California in San Francisco and Vanderbilt University are hoping to start trials soon. And it was pretty fascinating. Of course, they still got a few things to work out. That's why they haven't started the trials, but it's kind of nice to know that somebody's working on that. And that concludes. And as always, at the last page, I included a resource page for you of where I got a lot of my information.
Well, Laura, this was fascinating. I learned a huge amount today. Thank you for presenting that. Does anybody have any questions before we sign off? No? All right. So if there's no questions, then thank you again, Laura. And as always, Laura is a resource for all the transition specialists. If you ever have questions about someone that you're working with or more general questions, she is available by phone or by email to help you with any kind of medical questions. All right. Thank you, everyone.